Good afternoon, everyone. Thank you for being flexible with our change of venue over here today. And it's very likely we'll have more of these over here in the Bear Rock Cafe, so get ready. But I want to thank you all for being here today. I know you're all very busy. And as you might know, February is Age-Related Macular Degeneration and Low Vision Awareness Month. And that's really sponsored by preventblindness.org. So with that in mind, we have Dr. Manali Sakalkar here, an ophthalmologist right down the road. She is with Middle Georgia Ophthalmology. And she's also an assistant clinical professor with Mercer University School of Medicine, right? And just to give you a little bit of background, Dr. Sakalkar has been all over. She's been with her educational and her job career. She's been in Madison, Wisconsin, Staten Island, New York, Shreveport, Louisiana, Oklahoma City, Oklahoma, Brownsville, Texas, Gainesville, Florida, and now Middle Georgia. So we hope she's going to stay here in Middle Georgia. But thank you, Dr. Sakalkar, for taking the time to be here. And everybody give Dr. Sakalkar a big round of applause.
Thank you. Thank you.
Thank you very much.
Thank you. Thanks a lot, Barry, for that nice introduction. Good afternoon. It's a pleasure to be here. And I really love it in Macon, so I hope to make it my home. My husband also works here at the medical center, and he's a pediatric hemato-oncologist, and we have a 13-year-old son, just getting to be a mother of a teenager. I'm experiencing that. You know, I thought instead of just macular degeneration, why not make it some common eye problems that we encounter and which we all encounter at some point in time in our life. So these are the things that I'm going to talk about: dry eyes, age-related macular degeneration, cataracts, glaucoma, and diabetic retinopathy. So normally the eye constantly bathes itself in tears. Sometimes people do not produce enough tears, or the quality of the tears is not good enough to keep the eye healthy and comfortable. And this is what is called as dry eyes. The eye usually produces two different mechanisms of tears. It can make tears at a slow, steady rate to maintain eye lubrication, and then produce large quantities or copious quantities of tears in response to the eye irritation. If something falls in our eye, we immediately get more tears. It's a reflex mechanism, or in response to emotion. What does dry eye typically manifest as? Stinging or burning eyes, scratchiness, stringy mucus discharge around the eye, excessive eye irritation from smoke or wind. People are more uncomfortable during the cold weather, and excessive tearing, or discomfort or intolerance when wearing contact lenses. So typically, you know, we always think, oh, gee, it's just the tears. But the tears is a very complicated mechanism, complex mechanism. And there are three layers. There's an outer oily layer, there's a watery layer, and a layer of mucus. The oily layer is produced by there are meibomian glands in our lids. There are glands in the lower lid, and there are glands in the upper lid. And they produce the outermost surface of the tear film. They smooth the tear surface and reduce the evaporation of tears. Otherwise, tears would just evaporate very quickly. Then you have the middle layer. That makes up the tears. And this is produced by this lacrimal gland over here. It sits on the outermost corner over here, right here and right here. And that produces, and that actually helps to cleanse the eye. It has a lot of, the tears have a lot of antibactericidal properties and washes away foreign particles. And then you have the innermost layer, which consists of mucus. And that is produced by the conjunctiva, and that's the white part over here, which we all have. And that actually allows the watery layer to spread over the surface of the eye. What causes dry eyes? There can be several factors. One would be age, as we grow older, menopause, Sjogren's syndrome, which is basically dry eyes, dry mouth, and arthritis, especially the rheumatoid arthritis. But you know, in my practice, and I'm a cornea specialist, and I see a lot of dry eyes patients, one of the major causes is medications. And these are the main ones: diuretics for high blood pressure, beta blockers for heart or high blood pressure, antihistamines for allergies, sleeping pills, medications for nerves or pain relievers. How do you diagnose dry eyes? One is clinical examination. Looking through the slit lamp that I have, I can diagnose the dry eyes. Of course, history is very, very important too. Then there are some other tests which would help me. One is what is called the Schirmer test, and it is basically you put it in your eyes. It's a filter paper. It is graded. There are measurements on it, and you can actually measure the quantity of tears on that Schirmer test. And then you have these different dyes that we use. One is the fluorescent dye on the right, and the rose Bengal dye, and that tells me about the dry pattern. You can actually see dry spots in this picture, and you can see these punctate epithelial erosions on the right slide. How do you treat it? One is, we don't have tears, so we add tears. And the way we do that is we have different things available on the market. These are the tears, which will help to supplement the tears that we have in our eye. The second thing is, if the eyes are scratchy, especially when you wake up, then artificial tear ointment at bedtime, just before you go to bed, helps a lot. This is the ointment that you use. Now look at this picture. So normally, tears are produced here by the lacrimal gland. They flow through your eye, and let me show you this. They're produced here. They flow through your eye. Then we have two small tear ducts here, and then they go into the puncta, into the canaliculus, and there is a passage here which is called the nasolacrimal duct. Have you ever felt that when you put a drop in your eye, you feel it in your throat? And that's what happens. The tears, they flow through that passage, lacrimal passage as we call it, and that's how it comes into the throat. That's the regular drainage. Well, what we do is we try to preserve the tears for a longer time, and that we do it by putting a little punctal plug here, so that helps the tears to remain in the eye for a longer time. That's the tear duct, which is blocked with a punctal plug. Other things that would help is prevent evaporation by humidifier or pan of water on the radiator, avoid very dry rooms or hair dryers or wind or smoking. Like I said, the dry eye problems are more common during the winter time. And of course, the ointment works great. Cataracts. Everybody, or what do you call it, Cadillacs. So cataracts, it's clouding of the normally clear lens of the eye. It's a regular aging process. We all get it as we grow older. It's compared to a window that is frosted, and I have a very nice picture in my later slides, which will show you how you see and how somebody who has got really bad cataract sees. Cataract is not a film over the eye. It's not caused by, you feel like there's a film over the eye. It's not caused by overusing the eyes. It's not. It is not contagious. It does not spread from one eye to the other. And it is not a cause of irreversible blindness. It is a reversible blindness. It can be taken care of. It can be cured. So there is painless blurring of vision. Patient don't feel any pain. Sometimes it can cause glare or light sensitivity. Especially patients will say, gee, I'm driving at night and the lights from the oncoming cars bother me a lot. Poor night vision. Double vision in one eye. So they close one eye and they say, gee, I see double. They close the other eye, they still see double. Or needing brighter light to read. Or just fading or yellow colors. And it's amazing because my mom just had cataract surgery done, and she is the kind who didn't want to do this surgery for the longest time. And when she had the first eye done, she said, gosh, now I realize that I was seeing everything yellow. So she's like, how soon can I get the other one done? So people don't realize it. Now this is what you see. This is the clear picture that you're seeing. This is what a cataract patient sees, like a mist on their film. This is somebody who has got really, this patient probably is hand motion vision or just light perception vision. This is a white cataract actually. And then this is a pretty advanced cataract because you can see the yellowishness, and patient also has a posterior cataract. What causes cataract? Like I said, the commonest is aging of the eye. Family history. I do see patients who are younger and they have cataracts, and when you ask them, they will say, yes, it runs in my family. Father had it or mother had it, and so family history is important. Medical problems such as diabetes. Diabetes can bring the cataracts on very soon, especially if it's uncontrolled diabetes. Injury to the eye. Just recently I did a surgery on someone who had injury to the eye. He got injured just a few months back, and at that time I immediately checked him out after the injury. He was fine. Came back in 3 months, vision had gotten worse. And sure enough, he had a traumatic cataract, as we call it. Medications, especially steroids, and we use steroids for a lot of things like asthma or sarcoidosis. Lot of systemic conditions can cause, we need steroids, and for that, when we use the steroids, especially for a long period of time, we can get cataracts. Radiation, and then long-term unprotected exposure to sunlight, or previous eye surgery. And especially in this previous eye surgery would be something like a retina surgery, can cause cataracts after that too. How should cataract be treated? There's no medical treatment for cataract. It is surgery. And when cataract causes enough loss of vision to interfere with daily activities. Remember, it's not an emergency to do cataract surgery. It's an elective procedure. But usually I always ask patients, does it affect your day-to-day life? Is it causing glare problems that it's making you uncomfortable to drive? Is it causing you problems that you cannot sew or you cannot knit or you cannot read, or it's affecting your day-to-day functions? That's when you do the cataract surgery. You know, a lady who is getting retired may not want it as soon as a fighter pilot may be wanting it. But nowadays everybody is aware of what a cataract is, and so people want to enjoy their good quality of vision, and so this is something that people know very well. That's the cataracts. 1.8 million people have cataract surgery each year in the United States, and more than 95% of these surgeries are performed with no complications. They are performed under local or topical anesthesia. And what we do is that the cloudy lens is removed from the eye, and the focusing power of that natural lens is restored by replacing it with a permanent intraocular lens. This is what the lens looks like. And it is folded, and it goes through a very small incision into the eye, and then it just unfolds into the proper position. And this is a microsurgical equipment that we use. Again, after the surgery, you have to take eye drops as your ophthalmologist says you have to take. Macular degeneration. It is deterioration or breakdown of the macula. And if you look at this is a picture of the back of your eye. If your ophthalmologist dilates your eye, then that's how you look at the back, and this is the optic nerve. Let me show it here. This is the optic nerve, and this is the macula. And macular degeneration affects your ability to see near and far, and can make some activities like threading a needle or reading very difficult. This is how somebody who has macular degeneration, bad macular degeneration would see. So if this is somebody who is playing a guitar, a normal person would see the person playing the guitar. But if somebody who has macular degeneration, this central part of vision is missing. It does not affect side vision, it affects the central vision. This is again a patient who has got really advanced macular degeneration and now is having bleeding in the back of the eye, so he's going to need treatment for the same. And this is showing just drusen in the macula. So this is more of the dry kind, and we'll come to that. Dry macular degeneration is caused by aging and thinning of the tissues of the macula. Vision loss is gradual over the years. Wet macular degeneration is the worst kind, it's the bad kind. It can cause blindness. It accounts for 10% of all age-related macular degeneration cases. It results when abnormal blood vessels from underneath the retina at the back of the eye, they start bleeding. And they bleed or they leak fluid and they can blur the central vision. That's why you saw that gentleman where the central vision was just missing. Vision loss can be very rapid, can be very severe. So what are the symptoms? If you're reading a book, then words on the page would appear blurred. Or it could be just unnoticeable, especially if you have the dry kind. Or you could have a dark or an empty area appear in your center of the vision, just like that man with the guitar. The central part is not observed, just the peripheral part is observed. And if you were to look at this square over here, now this is a regular square, and if you were to read it with our reading glasses separately with each eye, the lines appear crooked and distorted, as in the following diagram. So how do you diagnose it? You know that graph that I showed you is called the Amsler's graph. And so a simple vision test in which you look at that chart that resembles a graph paper, and you can see, gee, my vision is getting distorted, is blurry. I can see some people in the audience already ready to do that. Viewing the macula with a special lenses. And then we have special tests with which we test in our clinic so that we can detect these abnormal blood vessels which grow in the eye. How do you treat it? Nutritional supplements like vitamin C, E, beta-carotene, and zinc. They have a special formula which is called the AREDS, AREDS formula vitamins, ocuvite, preservation, and these are the vitamins that are given for treating it. The wet kind is the one where you would need laser surgery, special kinds of injections in the eye which stop the growth of abnormal blood vessels in the macula. Usually, if there is any retina problem, macular degeneration problem, then I would diagnose it and I send it to my retina colleagues and they do the injections or laser. You know, we look at different things and based on what would be the best for the patient, they go about doing that. Again, you wish you could treat them all. You wish nobody was blind. But a lot of times, and especially with the wet macular degeneration, in spite of all the efforts on the part of the doctor, everything the patient does, still the patient does not see too good. And they are left with just very little vision. Well, then it's very important to rehabilitate the patient in those cases with low vision aids that will help them. And it's amazing because I still remember I did my fellowship in cornea, which is the front of the eye, and I do corneal transplants and in addition to cataract surgeries and amniotic membrane transplants. But when I was training at Dean McGee Institute, they had a great low vision aid specialist, and it was amazing because the vision which we take it for granted, and these patients who have advanced macular degeneration, and you give them anything like a magnifying device to a closed circuit television to large printing materials to they even have so that they can sign their checks, kind of a device. And it's amazing that they are so grateful that they can do their all these day-to-day activities which we just go about doing and they are very happy about that. It's a gratifying thing. Glaucoma. Now this is prevalent, this is big. It's a group of diseases that can cause damage to the optic nerve in the eye. And I think I have a picture. This is the optic nerve. I showed you the macula before, and now this is the nerve. This is the optic nerve. And as you can see, this is showing increased cupping of the disc over here. So glaucoma is a group of diseases that can damage the optic nerve in the eye. If left untreated, glaucoma can cause permanent blindness. Clear fluid is present in our eye, and that is what we call the pressure. Eye pressure, not blood pressure, eye pressure. And this clear fluid flows in and out of the small spaces at the front of the eye and bathes nearby tissues. If the drainage is slow or there is increased resistance to that drainage, then that causes damage to the optic nerve. Who is most likely to get it? African Americans over the age of 40. Again, anybody with over the age of 60, there is increasing chance, and it keeps on increasing every year, every year. Again, Mexican Americans. And most important, I would say, is people with a family history of glaucoma. So I always make it a point to ask my patients when they come to the clinic, mother, sister, brothers, and it's amazing how you will find out the history, the pattern in the family. What are the symptoms? This is the thing, unfortunately, that there are no symptoms. Vision stays normal at first because it's the side vision which is affected as the disease gets worse. But initially, there are no symptoms at all. And you detect it when you go for your regular eye exam, and the doctor may say, gee, Mrs. Jones, your nerves look a little suspicious for glaucoma, or your pressure is slightly on the higher side, so we'll keep a watch on that, or we'll do some testing for that. Again, the objects which are straight ahead, they appear absolutely clear, but objects to the side may be missed. When the glaucoma is left untreated, then the field of vision slowly becomes smaller and smaller. And even then, if it's right in front of you, it cannot be seen. Again, it's a slow disease. How do you treat it? Well, how do you diagnose it? So that's how, when we do a dilated exam. This is the machine that I have in my clinic, and that helps me to look at that nerve. IMD can perform different tests as well. And then we have medications. Actually, we have really, really good medications nowadays. And the medications have really helped to keep this disease under control. Laser surgery and then surgery, of course, in advanced cases is also available. You ready for the last one? Diabetes. These are the statistics. It's estimated that more than 170 million people are affected worldwide. And by 2030, the number of diabetics will double. And approximately 21 million Americans, which is about 7% of the US population, have diabetes. And as many 1/3 to 1/2 may be undiagnosed. So what are the symptoms? Diabetes and the eye. And nowadays, with increased awareness, almost every primary care physician who gets a patient in their clinic diagnosed with diabetes usually sends the patient to the ophthalmologist for a diabetic eye exam. Initially, the symptoms would be just a transient blurry vision, or the vision is all over the place. And that is because of the glucose levels. Sugar is high, you have one different prescription. Sugar is low, you have another prescription. Which is why if somebody comes to my clinic with fluctuating blood sugar levels, I tell them, let's hold off on the prescription, because wait until it stabilizes. You don't want to waste your money. And then once it is stabilized, then I give them a pair of glasses. The other thing is difficulty with near vision. It's accelerated in diabetes. Now remember, we all need, after the age of 40, we all need reading glasses. But somehow it comes on sooner. It's rapidly accelerated in patients who have diabetes. More susceptibility to infections. Now this is a bad one I've shown here. A bad corneal ulcer in this eye. And again, it's worse in patients who have diabetes. And there is some association of diabetes with glaucoma as well. What happens in diabetic retinopathy? The body normally does not use and store sugar properly. High blood sugar levels damage the blood vessels in the retina and the nerve fiber layer at the back of the eye that senses light and helps to send those vision signals to images in the brain. Damage to these retinal vessels is referred to as diabetic retinopathy. So what symptoms would you have? There could be no symptoms at all due to diabetic retinopathy, or you could have blurred vision. And I take trauma call at the medical center, and I had this very nice lady. She was 24, and she had diabetes for the last 13 years. She did not. She did not do an annual eye exam, but her last eye exam was about 5 years before that. She was. This was in the afternoon. She noticed like a little floater in her field of vision, and she said, maybe something is just bothering her. She went to sleep, and she comes back in the evening. She wakes up and she finds that her vision is gone. There is no vision at all. She was in a panic mode, and rightly so. I would feel the same way. And then she came to the emergency center, and I dilated her eyes, and I'll show you how we do that. And she had blood in her eye. She had that's why the hand motion. So that gradually over the few hours had gotten bigger. So it depends upon the location and the extent. You can have just leaking capillaries, and you can see this. This is not normal. This is abnormal. And so you can have leaking capillaries giving rise to swelling, hard exudates. These are some hemorrhages over here, and again some soft exudates or cotton wool spots over here. Again, the soft exudate that I showed you here, like a cotton wool spots. Or you look at the caliber of the vessels. I mean, they are all beaded vessels. This is not healthy vessel. And there is basically ischemia to the retina. That means the oxygen supply is being affected. Now this is what happens when it spreads even further. The widespread closure of the retinal blood vessels prevents adequate blood flow. Well, the body says, I got to help out. So the retina responds by growing new blood vessels in an attempt to supply blood to the area where the original blood closed. Unfortunately, these blood vessels are not doing any great work except bleeding on the surface of the retina. And this is how they look. So you can see these. These are fine, lacy looking vessels on the optic nerve. This is the periphery. That means it's way far out here. And these are abnormal blood vessels growing here. And sometimes they are so bad that they actually come onto the colored part of the eye, which is called the iris. You can see this. These are big, ropey looking vessels right on the surface of the iris. This is abnormal too. So you can have neovascularization. Whenever we have new vessels, we call them neovascularization. So neovascularization taking place. And when this is what the girl had in the ER, starting to bleed, because these are fragile vessels. They bleed into the vitreous, which is a jelly, right in front of the retina. And this is and it's filling up the center of the eye. Like I said, if it's small, the person might just see a small dark floater. If it is a large hemorrhage, block out the whole vision. And so if it's a big hemorrhage, and again, I refer it to my retina colleagues, if it's a big hemorrhage, then they might go in. Again, it depends on a lot of factors. How long has been the duration of the hemorrhage? How is it affecting the patient? And you might need surgery to remove the blood from the eye. Sometimes instead of the vascular part being more, it is the fibrous part or the scar tissue which is more due to diabetes. If that happens, then what it causes is a tractional retinal detachment over here. And if it is in the macula, again, it's going to affect the vision. This is how we check diabetes. So we first look at the slit lamp, and I can see the nerve and the macula. And then I look with the picture on the left, and you can actually have the patient look in all different quadrants so that you can appreciate the entire periphery of the retina to make sure that there are no diabetic retinopathy. How do you treat it? So if it is not bleeding, or if the bleeding is less, we can do laser treatment. And these are the laser spots that you see here. You can see that these are nice fine laser spots. And the whole purpose is that you cause the abnormal new vessels to shrink and prevent them from growing in the future. Again, for macular edema, if you have some swelling, which is more in the central part, just like the macular degeneration, which I said were affected more centrally than peripherally, then the laser is focused on the damaged vessels around the macula to decrease the fluid leakage. The whole purpose is to prevent any further loss of vision. And sometimes you even give injections in the eye. And these injections, intravitreal injections, are designed to shrink the swelling on the macula too. This is the surgery that I said, you go in, and if there's blood in the eye, which is causing impairment of vision, you can do the surgery and remove the blood. And tractional retinal detachment may also need vitrectomy. Vision loss is preventable for diabetic retinopathy. Early detection is the best protection against loss of vision. Strict control of your blood sugar, visiting your ophthalmologist regularly. When do you schedule an exam? Once a year, or more frequent eye exams may be necessary after diagnosis of diabetic retinopathy. That will depend upon, your ophthalmologist might call you sooner, might say, Mrs. Smith, it looks like it's a moderate disease, so I might want to see you every 4 months to make sure that it's not getting any worse. Pregnant women with diabetes should schedule an appointment in the first trimester. And again, if you need to be examined for eyeglasses, it's important for blood sugar to be under control before seeing an ophthalmologist. So they typically have your eyes checked when first diagnosed with diabetes within 5 years of diagnosis if you are 29 years or older. These are American Academy recommendations. Or within a few months of diagnosis if you are 30 years and older. But when they present with the type 2 diabetes, usually your primary doctor will send you and schedule the exam within the next month or so. Again, have your eyes checked promptly if you have visual changes that affect one or both eyes, last more than a few days, are not associated with a change in the blood sugar. Thank you very much. Any questions? Yes, ma'am.
The vitamins that you talked about as treatment for one of the problems, is that also good for doing as a preventative?
No, ma'am. That's a very good question. They looked at the ERIS study and they found out that it was not useful for preventing macular degeneration, but it is good when you have it and to prevent further progress of the macular degeneration. Yes, sir.
I'm going to put you on the spot here a little bit. Are there little simple eye exercises that we can do to help strengthen the eye or anything like that?
No, and I know a lot of times, people say, but the main thing I would say is good lighting, always have, good posture when you're reading, plenty of illumination, always wear, this is something I would say, it's not related to your exercise question, but always wear sunglasses when you go out, because macular degeneration, cataracts, even cancers around the eye. You might have heard about pterygium, which is a growth on the cornea. All these are related to the nice sunlight that we get, UV rays that we get. So always, and I would encourage you to tell that to your children, grandchildren as well. Start when they're young. I always keep a pair of sunglasses in my car, just so that I can, so that it's helpful. Yes, ma'am. Yes, blue-eyed, fair-skinned people are more prone to macular degeneration than others, absolutely. But just to let you know, my aunt, and I'm originally from India, she lives in India, and she just had bad wet macular degeneration in her one eye. They tried everything, and she has very little vision in that eye. So I would still say it goes for everybody to protect their eyes. Yes, ma'am.
Macular degeneration, hereditary.
It runs in families, absolutely. It runs in families.
Have you ever heard of something called an ophthalmic migraine?
Ophthalmic migraine, that's right.
I started having those a few years ago.
You know, and it's a very, you get phenomena, visual phenomena. There's no headaches.
Right.
Absolutely. It's different from classical migraine. And the main thing is to keep a watch. And they may do a visual field just to make sure that, you know, there is nothing else going on in the brain which is causing those phenomena. But other than that, and they don't cause any headaches or pain or anything of that kind. You started having that?
Yeah.
How is that going now? Still having it?
I may have 2 a year, you know, and that's it.
And that's it, right?
And they last less than 30 minutes. It usually affects one eye, and the vision's like looking through a kaleidoscope. You see all this turning. You know,
Absolutely.
And then it just gradually dissipates
And
back
gets
on.
better.
Yeah.
Mhm.
But
And
I was having a stroke the first time.
Absolutely.
And I called my doctor.
Doctor.
And I said, what is going on?
And did you, and how long does it last now?
Less than 30 minutes.
30 minutes.
Yeah. Because I timed them, and all of them have been less than 30 minutes.
And otherwise, you have no health problems? Okay.
I just figured I hit a certain age.
We can always blame it on that, right?
What's the term for that again?
Ophthalmic migraine. Or they can even say ophthalmological migraine. Ophthalmic migraine. Any more questions? Yes, ma'am.
Is Visine bad for your eyes?
Yes, ma'am. I call it, well, you know, if you want to, you know, my attending used to say it's the president's eye drop. So if you want to go meet the president and you want the redness out of your eyes, just use it for that little bit of time, but don't use it otherwise. So if you want to go to some meeting and you don't want the eyes to look red, you can use it. But other than that, it causes rebound redness. So I wouldn't use it. See, when you have dry eyes, the main thing is to treat the cause, is to eliminate the cause. That is important. Visine is not, it's not taking care of the cause. It's just kind of, you know, it's more of like trying to relieve the symptoms. Okay. Once in a while it's okay.
All right, and if you guys would like a copy of this PowerPoint, just email me, and then I can email Dr. Stalker.
Sure. And I was just going to show you one more thing. You guys have some time, right? I know somebody asked me this question about Middle Georgia ophthalmology, so I thought let me, and I had a slide here, and sorry about that. That's our team. We are located at 770 Pine Street, Suite 500. You can look up my website, mgoeyes.com. And we do comprehensive eye exams, glasses and contact lenses, diabetic retinopathy evaluations, glaucoma evaluations. I did an extra year of training, cornea fellowship. Well, actually I did 2 years. One was in Wisconsin, the other one was in Oklahoma. And I treat dry eyes, corneal infections. I also do corneal transplants. Pterygium surgeries, amniotic membrane transplants, and of course cataract surgeries. Okay. Thank you.